some issues with her internet connectivity, so she's trying to get on, but sends her best as well. And also Cecil for helping us put this together. So, the original idea for today's talk came from discussions within our task force for stroke continuity of care and transitions, and amidst all the changes that were taking place related to COVID, and just comparing and contrasting the experiences of our colleagues that were working in metro areas, and then those that are in clinical practice in less densely populated areas. So really appreciate Dr. Hall for joining us today, and for Dr. Kolberg as well. I'd like to share a little bit about each of them. Dr. Bryan Kolberg is a bilingual board certified rehabilitation psychologist at Gundersen Health System in La Crosse, Wisconsin. He specializes in working with adults with acquired brain injuries and chronic health conditions, and he is involved in training of postdoctoral fellows. He attained a doctorate in clinical psychology from the Chicago School of Professional Psychology and went on to complete a predoctoral internship at the University of Miami Jackson Memorial Hospital. He completed a postdoctoral fellowship in rehabilitation and neuropsychology at Rancho Los Amigos National Rehabilitation Center, and he is an active member of the American Psychological Association Division of Rehabilitation Psychology and is highly esteemed among his colleagues. Dr. Kolberg and I go back a little bit because we've trained under the same rehabilitation neuropsychology family at Rancho. And I'm also pleased to introduce Dr. Bryan Hall. He is the Director of Rehabilitation for Baylor University Medical Center here in Dallas, and Baylor Scott and White Medical Center at Waxahachie, and All Saints in Fort Worth as well. He works with the system leadership to help develop and implement the strategic planning and operations for the Baylor Scott and White Hospital therapy programs. Dr. Hall received his physical therapy degree from Bradley University, his MBA from the University of Texas at Dallas, and his Doctor of Physical Therapy from the University of New England. He has served in various leadership roles within Baylor for more than 15 years and various community service leadership roles with the United Way of Metropolitan Dallas for more than 10 years. He serves on the Curriculum Development Task Force and is committee chair and faculty for the APTA HPA's LAMP Management Program, and was adjunct faculty for Texas Women's University School of Physical Therapy. Dr. Hall has published and presented various leadership topics, including therapy value calculation, strategic planning, healthcare reform, quality improvement, pandemic response, finance, economics, negotiation, and organizational behavior. We are so pleased to have both of you topic experts joining us today. And we just really look forward to hearing your perspectives from the clinical experiences in rural areas and leadership and system perspectives here in the metro area. So Dr. Hall, time is yours.
All right. Thanks, Marlene. And thanks to the ACRM for inviting us to present today. So I have my contact information here. I'm always happy to connect with anyone from all different backgrounds. So please reach out. And any questions that come up after or anything that I can share with any of you and your organizations, I'm more than happy to do. For today, instead of providing a how-to set up pandemic care or telehealth strategies, what I want to do is tell you about some generalizable lessons that we learned along the way in our journey during this pandemic. And my hope is that some of our experiences and our path can help some of you lead your organizations through challenges you face along your path, whether it's a pandemic or different variant or something, who knows what. We can always learn lessons along the way, and we learned plenty of lessons last year and still are today. My narrative here for this presentation is through a leadership lens as opposed to a straight clinical lens, but anyone in any healthcare role, whether you're in a leadership role or not, can use some of these same lessons. If you want to really dig into more of the details on our what we've done implementing telehealth and with the pandemic, I have our publication we did here that goes into more details. Over here, we're for this presentation talking more of an overview. So as clinicians, we often use tools to enable quality patient care. And as we all found, the pandemic pushed us all to use all the tools in our toolbox to adapt to the barriers that we faced. And the better that we select and utilize the right tools for the job, the better our outcomes are going to be. So in this case here that I'm about to talk about, Dallas, telehealth was the tool for the job. So now let's take a look at how our Baylor University Medical Center PM&R program helped confront the pandemic challenges we all saw with successful telehealth implementation and what we learned along the way. So as with any public health emergency, we can expect to find anxiety. The less we know, the greater the anxiety. So from leadership standpoint, we have to understand the challenges in order to create a response. A coordinated response helps everyone mobilize their strengths and knowledge base to tackle the plan. What I want to talk about to you now is how we define the challenge, we design the follow-up plan, we tackled the plan and dove right in and followed through to make sure that what we were trying to set out to do, we're actually accomplishing. These four steps helped our BUMC PM&R program help confront the initial pandemic challenges that we faced in March and April of 2020. So getting started on defining the challenges that we were facing. As with all acute care hospitals, the patients are going to keep needing us, including those with COVID-19. We just needed to understand the situation, the patient needs, the coronavirus transmission risk, and the disease's symptomology. Then we could determine how to best apply our expertise to help the greater good. So this is what we were facing back in March 2020 when we admitted our first COVID-19 patients, as were many hospitals across the nation and around the world. So at that time, as the literature was just coming out, we knew that 20 to 25% of patients may require a prolonged ICU stay, and that many patients would require ventilator support, and the prognosis wasn't encouraging. Those who didn't require ventilation or the ICU may still require a prolonged hospital stay. And we knew that COVID-19 was progressing worldwide at a concerning rate, which could quickly overwhelm our resources. As a manager, the best way to plan through the use of resources to best serve patients comes from the manufacturing sciences, which describes a bottleneck as any resource whose capacity is equal to or less than the demand placed upon it. In this case, for all of us around the world back in the spring of 2020, the focus was how a patient flows through a hospital and what resources that they might need along the way. Our potential bottleneck resources were ICU beds, ventilator beds, and PPEs on the top of the list. The best way we could apply our therapy resources was expediting recovery to get people safely home to shelter in place, whether they had COVID-19 or they're here just for standard care. And we also had to mitigate any preventable decompensation that may require ICU or ventilator support. We needed to expedite recovery from this complex illness. And our epidemiology models were showing us that the bottleneck in Dallas, similar to around the world, around the nation here, would hit quickly and comprehensively within weeks. And we also knew from the evolving literature at the time, the disease progression, that we needed to intervene early before more severe symptoms manifested. We needed to intervene early despite the PPE constraints we were facing and the initial guidance to significantly limit clinicians entering the room to help decrease potential disease vectors. We needed to expedite care under these constraints, and we knew that it would require a telehealth strategy. So Alexander Graham Bell, he was granted the first US telephone patent back in 1876. And 50 years later, as the telephone adoption became more of a societal norm, a guy by the name of Gersbeck predicted in the magazine Science and Invention that soon patients could be treated remotely with such devices. About 40 years after that, NASA was actually doing it, monitoring the biometrics of its astronauts as they navigated space. So the pace of telehealth adoption, as we all know now, really was supercharged during the 2020 pandemic. Now, since telehealth laws, regulation, interpretation have been actively evolving since March and continue to, we chose a conservative route and followed Medicare's public health emergency relaxation of the telehealth rules, allowing PT, OT, and speech to conduct telehealth. So while exploring your local regulations in your state, you must also determine whether your telehealth application is considered on-site or not. So it's important also to note that unless the expansion of eligible providers becomes permanent following the health emergency, Medicare's current list of approved providers may revert back to its pre-emergency status levels, which could exclude potentially PTs, OTs, and speech therapists. So, and always remember that all elements of a live evaluation and treatment are required. And additionally, we asked all of our therapists to specify at the start of each telehealth treatment note and evaluation note when telehealth was used and that the patient agreed to its usage. So as we were looking at designing the plan to address the challenges, we knew what the disease process was, how our therapy expertise could be most effective, and how our constraints and bottlenecks we created could potentially get in the way. We then created the following vision and plan. So our plan needed to be based on evidence, best practice, had to be decisive and efficient, and there was no time for analysis paralysis. We literally had a couple days, a few days in order to create this whole plan, research it, design it, educate on it, and implement it. The COVID tsunami was coming quickly. The patients were coming in the emergency department on an hourly basis. So we created a COVID team who would serve as our local experts and practitioners in best practice and in process design, with process for scheduling. We had to create a telehealth strategy and educate the entire PM&R team accordingly. We had to communicate with key physicians and nurses and hospital leaders. We had to talk about why therapy was needed for these patients, what our plan was and our processes. And we had to have daily team communications to reassure our effectiveness and pivot as needed. Without regular and frequent communication, the best laid plan will die on the vine. So we divided up all of our volunteers, and so we called for volunteers and said, can anyone help us develop a plan? It's not mandatory, but we could use all hands on deck. And we happened to get a good 15 people to help us out. We divided them up into different teams. We had a COVID best practice team, a technology usage team, triaging and scheduling, and patient and staff education. There was no playbook. We had to write the playbook, and we had to write it within a matter of a couple of days. Each of these teams had specific time-bound goals and reported back at regular intervals. Now, while these teams I just mentioned were interdisciplinary teams, we then had to translate that through the lens of our specific therapies that we offered at the hospital, of course, physical and occupational and speech therapy, how they could use their expertise to really combat and address the pandemic that was evolving at a rapid pace. So our professional expert groups, digging a little bit more into how we divided up our COVID and our telehealth team. So we had PTs, OTs, speech therapists. We were trying to figure out how can we maximize recovery and prevent harm or decompensation. So our telehealth group then looked into technology options that we currently had, what we need to purchase, how to document, how to charge. We had a communication and education team who created communication tools for peers and other disciplines outside of PM&R. Patient education group focused on education while patients were in the hospital, what they could do, essentially home exercise programs for in the hospital room, as well as upon discharge. And we had a team to look at developing risk-benefit analyses on decisions including when we could go in rooms, when we couldn't, despite the PPE limitations that we were facing. This is something from our paper that we published. I'm not going to go into all the details. It's referenced there if you need it. But it was part of our education that we gave to our PM in our department. It talks about how when the consultation for PT or OT or speech comes down, we first of all would check where it is, is it in a COVID containment unit or with a patient under investigation. If so, our COVID therapy team would triage it. And they would use some of the algorithms that I'll show on the next slide here, but really talk about what are the risks, what are the benefits for working with this patient. We had still a significant PPE limitation at the time, and we still had the limitation of trying to keep as few of clinicians as possible in the patient's room, as we still did not know the full transmission risks back in March of 2020. This is the three-tiered structure that our COVID team put together that really looks at what type of patient is it, what are their needs, and what are those risks and benefits. So if I start at tier 1, those are the high consideration for direct care in the room. So when we had a patient come down, whether it's stroke or traumatic brain injury, fracture, polytrauma, spinal cord injury, heart and lung transplant, on ECMO or LVAD, those are the patients that we just had to find a way, we had to get approval to get in the room. For tier 2, those are the in-between that we had to look at a case-by-case basis. So more cancer patients, CHF exacerbation, COPD, myocardial infarction. And for tier 3, those are more of the general medicine patients that there's a good chance that we could handle a lot of our consultation recommendation and interventions via the telehealth technologies. After we had all our teams put together these algorithms, decision trees, and we had the education, we're fortunate that working with our IT folks, they were able to procure a number of iPads that they gave into the COVID positive patients' rooms. So all the iPads were loaded with Microsoft Teams, our HIPAA compliant version, and connected to our network in the patient's rooms. But initially, when the PPE was more limited, we would have to have the nurse set up the iPad with the patient, or make sure that it was facing the right way, volume was up, etc. And the nurse would also assist the PT or the OT or the speech therapist with any hands-on sort of care needed for the evaluation or intervention. Once our PPE supplies became less limited, the therapist would also provide more of the in-room care. But they could also now help their colleagues deliver some of the telehealth. So for instance, at that point in time, a PT or OT may be in the room doing their evaluation or doing a follow-up treatment while helping their speech therapist colleague with the telehealth portion, helping essentially work almost as a technician, helping our speech therapy colleague while they, as the PT or the OT, were already in the room with their intervention. So we also needed the entire PM&R team to actively consider other crucial patient care elements that really we should always be looking at, but that were amplified all the more during the pandemic. So when we look at, first of all, the social determinants of health, which again is something that's gaining, significantly more attention, fortunately, we have to look at it with Baylor University Medical Center. It's in downtown Dallas, so we have a lot of underserved groups that we work with. And of course, at the time, we didn't have these data points. These came out just a couple of months ago. But sure enough, what we found is that in 2020, there was significant life expectancy decreases, especially in the Black and Latino populations. And then furthermore, especially in Texas, a lot of states in the union also have uninsured, of course, but Texas usually always has the highest possible uninsured of all 50 states. And then a number of underinsured on top of that. And what you can see here by this graph on the left side, the left graph, when it gets towards the end there, you can see what happens with when the ACA came out in about 2013, there's a big dip in the uninsured rate. But then you can see at the very, very right side of that graph, it comes back up as more and more people were losing their jobs in the spring of 2020. So our uninsured rate was going up. The graph on the right side talks about in February to May 2020, also because of the job loss, and it shows actually in numbers, we actually had in Texas about 650,000 more uninsured people due to that acute job loss that they were facing. And these are the same folks that were coming in our door who were needing a lot of care. So what does this all mean when you're looking at a P&R department? So we have to rethink all of our care strategies with an eye on resources and restraints. We have to look at expediting recovery and preventing decompensation. We have to clear up these resources. We have to expedite care. And this isn't just for patients facing COVID-19. It's for all of our patients, so we can free up these resources and get them home safely. We have to really consider the uninsured and the underinsured, and also the social determinants of health. They're also at play, but are getting amplified radically during times like the pandemic. And then maximizing expert resources, both inter and intra-departmentally. We had to really work together better than we've ever worked before. So second, you really have to build an interdisciplinary response team. You can't just work in a bubble here. I know you really never can, but it's all the more important here. You need to pull people together from all the different disciplines, have them synthesize the literature if it's not there yet, whatever you can pull together, establish and implement best practices if ones don't exist already. You have to adapt logistics for efficiency and effectiveness. When you look at 3-4 staff stress levels, that's something that we learned along the way. Of course, we didn't know it in March and April, but as we're working out just the chronic stress, potential burnout that we face, that's something that from a leadership standpoint, we really had to try to actively address, encourage people to take time off, to get away. Even if the census was high, we had to have people take time for themselves, get the help and the support they needed so they could keep serving their patients. We had to monitor and evolve the situation actively. And we had to really tell people, avoid rigid ideologies. You know, you're not just an acute care therapist, or you're not just a rehab therapist. You have to see yourself as, what if the patient doesn't receive any other care? You are all the types of therapists, or they may be underinsured. You have to be able to meet everything that they need. So just to kind of tie it all together, I have my references here. The quicker that we found you could dive into this, pull your best people together, create the team and the plan, the better off that we could survive. So we learned a lot along the way, and hopefully some of these lessons will help all of you out as well. I'm going to now turn it over to Bryan to share his story.
All right, thank you. And thank you everyone for having me. I'm going to come at this more from the general clinical side. And in doing so, I'd really like to just talk about how our institution adopted telehealth. And really this was done not just within PM&R, inpatient and outpatient, but our health system as a whole really had to roll this out rather quickly in the face of the pandemic. And fortunately, being in a less populous area, we weren't hit quite as hard as some of our colleagues in urban centers. And so with that in mind, we had less usage of this in the hospital setting as our COVID census in terms of who we saw on rehab was generally lower, but that also allowed us to use more one-on-one contact with the patient in the room with PPE, full PPE on. So we didn't exactly get the chance to use this too much on the inpatient side, although I'll get to how we did it. So just to get a little bit of a background on us here, starting with Wisconsin as a whole, we're a largely rural state with some urban and semi-rural or semi-urban centers. The Milwaukee metro area being the largest and perhaps most recognizable for people outside of Wisconsin. But then we have Green Bay, Madison, Janesville, La Crosse, and Eau Claire. and within between those urban centers, a large rural population mixed in. So we have major health systems serving large portions of the state: Aspiris, Aurora Health, Berlin Health, Gundersen Health System, Marshfield Clinic, UW Health, and Theta Care that serve different regions of the state. But each health system itself has a fairly large catchment area that we serve. So we have patients that come to us from quite a distance down rural routes and country roads, and it takes a while to get here. So telehealth has been on our minds for a while and in use to some extent since 2005, as I'll talk about in a second. And because it was to the benefit of our patients in our area to be able to see their providers from a distance without having to drive or otherwise cluster their appointments. So one of the big challenges in an environment or in a state where we have primarily a rural population is internet access, in particular broadband internet access. So Forward Analytics did a study on this put it out in 2020, but evaluated internet access in Wisconsin in 2019 and found that, as perhaps could be expected, the broadband access was not uniform across the state, with optimal access, meaning the highest speed and the best technology available in more urban counties within the state. But the good news was that 10 plus megabit per second connections were more widely available across the state. However, for those counties with 25 plus megabits per second, 15 or more, or 15 counties had more than 10,000 people without access. So in each of the additional 24 counties, 5,000 residents lacked access. So there's still, as far as the availability of at least 10 or so megabits per second connections were available to Wisconsin residents more widely, the faster internet with the fiber connections was kind of limited to more the urban areas. So the report found that overall, about 70% of Wisconsin residents had access to broadband with connection speeds in excess of 25 megabits per second, but that was across fiber optic, cable, and fixed wireless connections. But only 20% of residents had access to broadband with the best technology, which was termed to be fiber. So that poses real challenges for trying to conduct visits over large distances, obviously, with our people in our outlying communities, because sometimes there's lacking the speed or the quality of connection that limits the availability of the service. So a little bit about Gundersen is that it's a health system serving western Wisconsin, southeastern Minnesota, and northeastern Iowa. So we serve a tri-state area, and within that, a large area of patient populations obviously come to us from those states, as well as western Wisconsin more largely. We're based in La Crosse, though we have a large service area with satellite hospitals in different communities. And so our connections have to be established within those communities at those hospitals themselves, but also with the patients themselves in the surrounding areas. So, as I mentioned before, the use of telehealth has been at Gundersen Health System since 2005, though obviously, like others, we made a large investment in development of the use of it in 2020 during the COVID-19 pandemic. And where it was used for a large part in the past was communication with our neurology service for stroke consultation within the emergency rooms at our feeder hospitals or satellite hospitals in rural communities, where our neurologists could do the consultation with the ER staff and guide the administration of alteplase or other interventions, or at least to get the patient ready for transport and airlift to La Crosse. But at least to conduct the initial assessment of them in the emergency room was done largely by a telehealth in our extended communities. But presently, we have telehealth being used in 29 communities in the Wisconsin, Minnesota, and Iowa service areas, 140 clinicians across 43 specialties providing telehealth services, and currently approximately 160 visits per month. So our use of this has exploded in large part, with our larger goal of having in the high 20s, about 28% of our visits as a system as a whole to adopt to telehealth. So this required a massive investment in capital, as well as the guidance of our leadership, who took this on as a whole to plan and then pass this down to the clinician level. And unfortunately, as a clinician myself, I am not involved directly in hospital leadership. I'm not privy to the specific plan with which they used to unroll this. But as far as being able to show the general timeline here, in the spring and summer of 2020, we invested heavily in technological resources, so equipping clinic staff and with multiple monitors, cameras, clinic rooms that were converted for providers to conduct telehealth visits. Our initial platform that they chose was Skype for Business, although this had its problems and security concerns. So obviously that involved providing informed consent, first and foremost, to the patients and using this platform, as we contracted and got a more permanent platform, which we now use as Amwell. And so that included in our documentation, obviously, that we're conducting the visit via telehealth, and explaining to the patients at the outset what the limits are of the service, as well as the potential benefits. This involved also rapid training of the staff in the use of telehealth, so creating super users to distill the information down to the clinician level, as well as all the way to our MA staff, who would otherwise be rooming a patient if the patient came into the clinic, but in the case of telehealth, rooming them virtually to get them ready for the provider to come see them. And so with our therapists on the rehab side conducting the telehealth, they didn't have mid-level staff assisting them. They were mainly doing this themselves. So this required quite a bit of education at the staff level and dissemination of the information to them on how to operate the platform, how to use it effectively. But now with Amwell, that is more integrated into our electronic medical record system, which is Epic. And that enables us to open the visit and connect with the patient through the MyChart application as well. So in addition to all of that, the advertisement of our telehealth capabilities to get people to gain comfort with this. So as I'll discuss in a second, the main barrier in a lot of ways was technological literacy and access to the technology that made it hard to connect with people oftentimes. So as I mentioned earlier, with the variability in internet service and quality of connections, that made it difficult to connect with people in particularly remote areas. And so unfortunately, that made it harder for our patients who are coming from the more remote areas to connect with us. The connections oftentimes were adequate, but it obviously did not measure up to the quality of a face-to-face visit in person. But it was the best we had, especially when clinic operations were closed down due to the pandemic itself and the recommendations to keep staff and patients safe. The technological literacy of the patient populations posed a barrier at times. We had to create a technical support line for people to call and access. Number of people were not comfortable using telehealth, for even despite the assurances of the level of protection and security we could offer, even through the Amwell platform, people are still hesitant to do that because of the concern about this being communicated over the internet and so forth. And cognitive impairments, especially in our people with stroke and traumatic brain injury, made it difficult in some ways for them to operate the technology and access the visit that way. And so ultimately, while attempts were made in times to connect with people via telehealth, once we did open the clinic, to be able to have people come in face-to-face or in-person visits if we could, if they were having trouble with the technology itself. So the other barrier was that for a long time, even after our clinic opened back up, we still, to protect the nursing home populations, we restricted visits for patients who were coming from the nursing home to really only the absolutely immediately medically necessary procedures in the clinic, and anything else, if it could be done via telehealth, was strongly encouraged to be done via telehealth. And so trying to access people in a skilled nursing setting, you're dealing not only with the connection issues, but also the privacy concerns if a patient is in a shared room, or if staff is having to assist the patient in setting up the technology and then closing the technology down once the visit is concluded, creates some challenges for our therapists as well as our providers, including myself. So that was one of the challenges of trying to navigate that and being able to manage confidentiality when you can't readily control that on the patient's end. And lastly, in terms of general challenges, because we serve a tri-state area, we had to ensure that people providing telehealth to patients across state lines had to be licensed in all those states. So that involved having our providers licensed in not only Wisconsin, but also in Minnesota and Iowa if they were not already. So that created another challenge, and of course a lot of paperwork to accomplish that. So because we're in the location that we're at, that was a barrier that was unique to us in that we serve people from 3 different states in our regular practice. So in terms of the inpatient rehabilitation, one of the challenges we had initially is just really trying to wrap our heads around how does this fit into inpatient care. And for a time, our visits or hospital restricted visitors so that we could not have any outside visitors in with patients during the worst of the pandemic. So at that time, family meetings were completed over telehealth, usually via phone, because that was the most readily accessible. You could have family at home, have them use their speakerphone. We could use ours, and it was easy to connect with them in that way. Although there were some virtual family meetings conducted as possible and as able based on the family's ability to do so. But as visitor restrictions were relaxed, we were able to then have them come in and do meetings in person and do the education in person, although it was used for education, again, during those times when visitation was restricted. But also we used it in some ways, or our therapists use it to get a walkthrough of the patient's home or home setup. So family can bring in pictures and measurements and that, but sometimes it was also helpful for our therapists to actually do a walkthrough with the family so that we could get an idea of what the home setup was like to recommend equipment and home modifications and so forth. Whereas before that might have been accomplished by a home visit. Obviously that was not possible during the height of the COVID-19 pandemic. Being able to do that virtually was a big help. So in preparing for this, I did speak with a number of our PT, OT, and speech therapists, being able to see how they've used it and what their challenges and benefits were. So in terms of occupational therapy, the primary populations they saw were people with stroke, ALS, and Huntington's disease, and primarily used it for developing home exercise programs, but also the ability to check in with patients and upgrade the programs as needed. And as kind of on the inpatient unit, being able to use that for a virtual home visit to also monitor the patient in their home environment to be able to see, okay, how do they interact with their surroundings? How do they manage the physical or cognitive limitations that they have now in navigating their environment, and being able to see that in real time instead of extrapolate based on what the patient and the family are reporting their home layout is. They can actually see somebody in their home and working with them then. So this was particularly beneficial for people who have limited access to transportation. In the area in which we're situated, La Crosse has a bus system, and we do have the the Amtrak train that comes through, but we really don't have a large public transportation infrastructure. And so it's very difficult for people to get to their appointments if they don't have access to family to drive them, or to agencies that do transportation. But then again, they're reliant on scheduling those in advance and the drivers coming on time and picking them up. So if they didn't have to deal with that and could come and be seen via telehealth, it was also very helpful. And the same thing with mobility limitations affecting their ability to come physically to their appointments. Telehealth was particularly beneficial. But again, the technological literacy and being able to use the technology, whether that was influenced by technological literacy or through cognitive impairments, that was some of the challenges that our OTs faced. And when problems did arise, the time spent troubleshooting and trying to be on the line with tech support and helping the patient sometimes took away from the visit time. which then was a lot harder to accomplish what they had set out to accomplish. So with our physical therapists using telehealth with individuals with Parkinsonism, ALS, stroke, and vestibular concerns, and like their OT colleagues, mostly use these to assign and monitor progress in in-home programs. And with the benefits of, again, being able to see the patient in their home environment as well as get an assessment of the home setting, but then being limited by the limited access to the hands-on work of PT and not being able to do much in terms of the objective testing of an individual over telehealth. And in a lot of ways, that's where it's limited people in my service in the neuropsychology section is there's limited testing that we can actually do over telehealth without someone on the other side manipulating the testing materials for the patient. So trying to get actual observational data through more objective means can be kind of challenging over this as it was for our PT colleagues. Our speech therapists primarily use this with individuals with TBI and stroke. And again, as with our other colleagues, the increased access to those visits for those with limited mobility or limited access to transportation was particularly useful. But again, the connection issues due to internet service in rural areas, patients requiring a support person to operate the technology. And obviously, our speech therapy colleagues often assign homework or paper and pencil tasks for a patient to do. Very difficult to do over telehealth, still possible, but it also made it a little more challenging for them than a standard office visit. So we're still in process of further adapting this and working with telehealth with a larger goal of increasing access to telehealth simply because of the area that we're in. It's far more helpful for people to gain access to us that way than coming all this distance. And especially as if anyone's familiar with weather in Wisconsin in the winter months, it becomes also very challenging. Roads can become impassable and a lot of times people can't make their appointments because of the weather. So telehealth can also become something that's very useful for us as well. So that's the larger context in which we're in here. Again, trying to come at this more from the clinician standpoint, I hope it was helpful to see how we as a semi-rural hospital system here has adopted that.
Well, thank you so much, both Dr. Hall and Dr. Kolberg, for sharing your experience and expertise. We're going to open it up for questions. So you can either share those here out loud or type them in the chat. And while some of those other questions come through, I'd like to ask you to tell us about how you were able to address billing and reimbursement issues. And are there any practical recommendations that you could share with us?
For billing and reimbursement, I really can only speak to my service as far as how that was run. We were able to, we fortunately have a rather robust and well-connected prior authorization department who works very closely with us. And so who would review as the guidelines were changing in response to telehealth and being more relaxed in terms of what could be provided and billed for, they were oftentimes abreast of that. But a lot of that ended up falling on us in a lot of ways to figure out, okay, what is covered and what are the unique nuances to our documentation that then have to take place. So our section as a whole kind of divvied up those responsibilities amongst us, and we then did our own research in that respect. And so for my purposes, doing continuing education, particularly as it pertains to the psychological provision of care and what we need to do in our documentation there. But the institution is a physician-run institution, and so we pride ourselves in having our physician leaders who also trickle down into their departments. And so much of our other departments acted in the same way of trying to figure this out and get ourselves in a position where we could make these a potentially profitable way of handling care.
Thank you. And we had a question come in through the chat For both speakers, what do you think are important considerations in establishing a post-ICU/COVID recovery clinic to see this population through, both at the leadership and clinical level?
That's a great question. You don't have the best answer for it, but I think right now in the United States and in probably many countries around the world, we're not doing a great job within healthcare meeting the post-ICU and COVID long haul recovery needs. There's a number of really great clinics. I know Michigan has one. I believe Vanderbilt. There's a number of other ones that do a great job, but I think we would do a lot more. And I think especially when you look at trying to improve the long-term outcomes of patients, whether you're in more of like a capitated model of care or not, the literature is pretty clear that the better that we can work with these patients, the better we can help them get back to work, get back to life, and lead productive lives. As far as how to actually considerations from setting up from a leadership standpoint, I think a lot of the times we can use some of the exact same structures as far as billing and coding that we would for any other type of patient that we would see, and then work really closely with our finance departments, whether we're outpatient or rehab or home health, and combine that with the literature that talks about, that's been talking about for years with the post-intensive care syndrome patients, the needs we have. So we can combine the needs that they have and how we can actually mitigate some of those long-term sequelae, the financial implications of if we don't, along with there will be some reimbursements if we actually do this. And I think it makes a really sound financial case and how we could set that up. I think secondarily, it's easy to set up current outpatient therapy clinics, whether they're more rehab oriented or even orthopedics oriented, to be able to handle a lot of these patients. The clinicians will of course have to do some of the more specialty training within some of the more ICU syndrome, that whole constellation. But other than that, it's feasible. I believe it can break even and keep the doors open. I just think it's something that a lot more organizations need to dive into a lot more.
Dr. Kolberg, is there anything that you want to add to that?
Well, for our purposes in rural settings, we know, especially from the literature, about the importance of the relationship in the community, that rural communities tend to be tighter knit and more trusting of the people within their communities. So I think what's been beneficial about telehealth is that it brings access to providers, trusted providers, closer to the patient because they don't have to travel. And so what it also allows us to do is to have greater access to the patients, but also having the patients have greater access to us. So even if post-COVID, if they're having to see specialty care, if their regular doctor can connect with and recommend a specialist within the La Crosse area, say, to be able to see a patient in Iowa via telehealth, by extension, that can create greater access to care that way. So I think within that, it becomes, instead of the specialist in La Crosse being viewed as some nameless, faceless person that they have to drive 2.5 hours to see, if they can see them from the comfort of their living room, that makes it a lot more accessible to them and brings that community a little bit closer together. So I think that's where we can potentially benefit from doing that. And with the use of telehealth to do regular rechecks or just follow-up appointments where perhaps specific studies or anything that's invasive doesn't need to be done and it's more a check-in, the access to care becomes better and the patients are more likely to come see us.
That's wonderful. Thank you. And I also want to share along the lines of this question, a resource that's going to be coming up at the annual conference by one of our task force members, Farha Ikrak-Mudin. She's leading out a symposium titled Innovations in the Continuum of Care for Rehabilitation Teams in the COVID Era. In this symposium, there are going to be 2 different models discussed of how new programs were created to address these specific needs. One in a more type of inpatient or kind of a transitional program for post-COVID patients, and another outpatient program called COVID Recover. So for those interested in this topic specifically, I'd encourage you to plug into that symposium as well.
I think that's all we have for questions. Thank you, everyone. This recording will be available. It takes a little bit of time, about 24 to 48 hours. We'll pass it on. We'll get a little bit more legs, let's say, for this presentation. But thank you to our speakers, Dr. Hall and Dr. Kolberg, and Marlene. Thank you for your work with the Community and Transitions Task Force. It's part of the Stroke ISIG. Dr. Rowe is here as well. Thank you so much for spending this afternoon with us.
Thank you. It was a wonderful presentation.
Thank you for your expertise. Bye-bye.
Bye-bye.